Today we have a 62-year-old woman with a history of a prior upper blepharoplasty. She presents today for a panfacial rejuvenation. We've chosen for her a brow lift, a lower lid blepharoplasty, lower face neck lift with deep plane approaches in both places, a conservative lip lift, a little bit of fat transfer, some laser resurfacing. So our patient today is going to be having a temporal brow lift, and we're going to do this in a gliding fashion. She'll be having her lower lids with a transconjunctival blepharoplasty, fat transfer, and we're going to do a full face laser resurfacing, not just the lower lids. She already had her upper lids done 14 years ago, roughly, and you'll see that she doesn't need any further attention to that. We'll be doing a deep plane lower face lift, deep neck lift, and then a conservative lip lift just to complete the package. And so if you get in close here, we're going to simulate a couple of these things and then do some drawing. So on the brow lift, I like her central brow where it is, and she has a little thinner, drier skin. So for her, I really only want the outside corner lifted. And in this case, I feel like I have, between the two brow lifts that I still do with any frequency, the endoscopic style and the gliding, I feel like I have better control with the gliding brow lift. So we're going to actually do that. Looking at her, she's got a little lower brow on this side, so I'm just going to make a little mark here. Can I get a heavy marker? I'm just going to make a little mark here for planning to, in the operating room, keep that in mind, that that's her lower brow. And as far as that, that's pretty much the only marks we need for the gliding brow lift. I could potentially make a couple of marks here just for access, but it's not as, we really don't have to mark the temporal fossa or anything like that. So the only thing I mark for the under eyes is the hollows. This is where the fat transfer is going to go. And as far as how much fat we remove, that's an intraoperative decision, so there's really nothing to mark there. That's the under eyes. I'm going to mark the midline of the face. I'm going to mark where the major final skin wrinkle is. And just for my operating room team, I'm also going to mark where I want a minimum extent of local anesthetic to go. So for the sides here, I'm going to mark where the actual cartilage of the root of the helix joins the face. We're going to be real careful in the operating room. We get this sharp corner on the top part of the tragus there. She's got a really nice crease in front of her ear. We're going to use that. Bottom of the tragus. That's going to be our temporal incision. On the back, she doesn't have, her actual hairline is kind of back here. And she really doesn't have a point. A lot of times where the helix will cross the hairline, she really doesn't have a point. So we're going to kind of make one and mark her postauricular incision. This is actually going to go in the lobule sulcus and then straight vertical, because that's the way the Burroughs triangle is going to go. And then we're going to turn this down and kind of make a hair edge incision. So we had to kind of make a decision on her. So for our incision, she's got a really good crease in front of her lobule here. We're going to use that. We're going to be retrotragal. We're actually on the free edge of the tragus. We're going to make sure I make a really sharp peak there at the top edge of the tragus. I'm going to follow the helix, the root of the helix. And then a little temporal tuft extension. Just like that. On this side, she almost has a helix hair touch point, so that's going to be there. I'm going to follow the hair edge down. And then a straight line design, because if we make this up and blunted, we have to pull the flap this way, which is unnatural, and it broadens this part of the incision. So it's going to be a straight line design, which is the direction the Burroughs triangle wants to rotate. And because this is not under tension, this narrow part does great. And also, you're not a smoker, correct?
Correct.
Yeah, so that makes a difference too. So I'm going to make some marks again for my operating room crew, the extent of the local anesthetic, the kind of minimum extent of local anesthetic. The last thing, I'm just going to mark where her pre-existing submental crease is. I'm going to tip your head all the way back. And then we'll fine tune that in the operating room, but at least I know where her crease is. Good. So we're getting ready to mark the lip lift. And with eyelids and upper lips, I like to take the natural oil off the skin so our marks stay really crisp. And we're going to start out, our calipers are at 13 at the Cupid's bow, and that's perfect for her. She doesn't need a real aggressive lip lift. That's going to be just perfect. So that's the degree of excision I'm planning there. I like to do my first mark with the Sharpie, and then I can finalize it with a purple marker. Because the Sharpie I can alter as needed. So to alter this, we can use a damp Q-tip and wipe it completely clearly off. Make any changes that we want. So once I have that right where I like it, now I'll go ahead and cement it with a surgical marker. Thank you. That's just to keep it from blurring. All right. Then the last thing I need to do is I need to mark where I'm going to take some fat from. Have you had any surgery on your belly before? Mm-mm. Okay, good. All right, so we're going to start with our transconjunctival incision. Through the conj and retractors. Fire it up for me. Okay, stitch please. And then we'll retract the posterior lamella posteriorly. Okay, now I'll get between middle and anterior lamella with some blunt dissection here. Got a little bit of a tight lower lid. Another Q-tip, please. I wonder if she's had a lower bleph before. She doesn't say she has. There's her temporal pad. She's a little tight. Again, I wonder if she might have had some fat removed before. I didn't see an incision, but she's kind of sticky. So we can get a sense of her nasal pocket here, middle and temporal. Let's start with the temporal pockets. Take that. She doesn't have a ton of fat in the lower lids, so I think she may potentially have had a little taken before. So it's the superficial component of the temporal pocket. Here comes the middle pocket. Slide a little bit. There's hardly any here. Slide a little bit more. Okay. Almost nothing. Inferior oblique is going to be right in here, but again, it's a little bit kind of tight and scarified. Here's the nasal pocket. And she has very little there too. She's more of an empty bleph than a full bleph today. Come on, let's just see where we are. So the goal is to have, with a little bit of gentle pressure, the fat pocket sitting at the level of the orbital rim. So she's pretty close. There's a little bit right here. Out for a sec. That looks good, and we're going to investigate the nasal pocket. Come back in. That's clearly it right here. Q-tip again, please. It's abnormally tight and sticky there. Q-tip, please. Inferior oblique is right here. Again, there's very little. It's not spilling out the way it usually does if there's significant fat. Come out. So not much to remove on this lower bleph. So it's more important what you leave than what you take. And I'm content with that. So same thing, Megan's pulling the anterior lamella towards her. I'm pulling the posterior lamella towards me. They're almost at 180 degrees. And by doing that, it really decreases the chances that we buttonhole with this incision. Come a little closer to the lash line there so you can get better tension on that. Okay, stitch please. And again, we're going to take the posterior lamella posteriorly. Clamp it up out of the way. Thank you. And blunt dissection. There's the temporal fat pocket. And a better plane on this side. She also has more fat on this side. Q-tip again. So we'll overlay her photos for you, and you'll see in her photos she actually has more fat on this side, and it's showing in real life as well. Okay. So that was more normal. Take that. Q-tip and a bovie. Okay. So here's her temporal fat pocket. And even this side, it's got more than the other, but it's not a lot. Okay, dry it up, please. Okay. Here comes her middle fat pocket. Again, not a whole lot, but more than the other side. Okay. Dry it up again. Okay, now I'll go nasal. So there's inferior oblique showing. Go nasal to that. Same thing here, real tight. Not a whole lot going on here. It's more middle fat. Let's see, I'll come out. Hold that. Bovie, please. Like that. Inferior obliques here, it looks like. Her anatomy is not as obvious as many. Oblique, nasal fat. Out again. Still a little full there. Dry it up, and then come out after that. That's better. Let's take one look right over here. Okay, and come out again. Yeah, okay, so I'm satisfied with that. Now, we'll move on to fat transfer mode. So we've taken the very subtle bulging that she has away, and now we're going to fill the general emptiness in that area. We're using outer thigh for her donor site today because she had softer, butterier fat there compared to her lower belly. There's a little more that's kind of recurring here temporally. I'm going to take that. Became visible after we took the stitch out. Out, please. That's better. Okay, let's harvest fat. So we're using this no-core needle to make a stab here. It was infiltrated earlier in the case. And then this is I think it's a 2 point, is it 2.4, Joni?
3-port cannula. And lower thigh or outer thigh fat typically is just better quality. It's buttery and soft, and so if they have outer thigh, it's become my preference fat compared to lower belly. And it's easily accessed when they're supine, which is nice too. And I'm as deep as I can be when I harvest this. Minimize the chance that she sees anything. Good. So I'm pretty much on the deep surface of the fat pad against the fat and the fascia. And this part usually is the most sore part of their whole recovery, is the fat harvest. So we put some Marcaine in there at the end, trying to minimize that. We use the same tumescent mix here as we put in the face and the brow. We use just one mix for the whole case. And it is 750 milligrams of lidocaine, 1 gram of TXA, and 2 cc's of 1 to 1,000 epinephrine per liter. So it's the same mix everywhere in the face, in the head, and the donor site. So we used the same no-core needle and made a few different stab wounds. Make as many as you need to get easy, even access into there. So if you're finding it's hard to fill a spot, make another stab wound, make as many as you need, so they don't leave any marks. All right, so this is a Tulip 0.9 cannula, and we're gonna use this to start our fat transfer. And it's just like with the harvest, we start as deep as we can and put as little as we have to into the superficial layers to get as even fat transfer as we can. This usually ends up being 1 to 2 cc's into the tear trough region. I'm coming from a few different angles to get for an access and make it even. So this was centrifuged for maybe 30 seconds, not a whole lot of time, at 3,000 RPM, and then drained out on a Telfa, just to get the consistency uniform from one patient to the next. That's getting very close. So now I'm working a little more superficially for fine tuning. That looks good. So that was 1.5, almost 1.6 cc's on that side. Let's start the other side. Same thing here. We're starting deep, working our way superficial. Tiny little aliquots. Trying to make it as even as possible. I'm going to make another stab. I'm having a little hard time filling this spot, so I'm going to come even more lateral. See if I can get it from a little different angle. That's helping. Pretty superficial now, also trying to get that little last divot to fill. And part of it's just the action of making all the passes helps break it up. It's working well. That looks good there too. Okay, so that was 1.7 on that side. So now we're going to build her zygomatic cheeks a little bit and temples a little bit. So zygomatic cheek, I'm going to use the same ports and have just a longer cannula to get into the high lateral cheek. That's one. And this helps expand the mid-face, which is a pretty youthful look. So, let's see. Good. Okay, so I've done 2 cc's in each zygomatic arch, which is enough because we are going to get some volume replacement with the mid facelift, or the upper portion of the deep plane facelift. I'm going to do a little bit in each temple. Okay. I'm just going to feather out her temple just a little bit here. That's one. So you could put this deep to the deep fascia, or you can put it superficial in the temporoparietal fascia. If you go superficial, you have to make sure it's really well feathered out so it's not lumpy. Kind of like it's superficial. I think it helps the skin tone a little bit as well. But neither one is right or wrong. Let's see. That looks good. So the temple anywhere between, I don't know, 2 and 8, depending on how empty they are. And I'm building a little bit into the lateral infrabrow, just kind of blending into that area with this. One. We don't do any microfat or nanofat or any of that stuff. We've played with it, but really haven't used it. So then I like to look from the top of the table and look for the malar projections, the zygomatic arches, the temples, and get some sense of what everything looks like. And I think that all looks great. All right, on to facelift mode. So we're going to lower her head back down, Joni. Bovies to 30 across the board, please. All right. Okay. So we have our midline marked. We have the lowest meaningful crease in her neck marked as well. So those are kind of our landmarks. This is her dominant submental crease. I like to use the actual crease. You can go behind it. Pretty much never go in front of it. So we're going to start back undermining the chin fat, because that will give us access to the mandibular ligament later. Make it easier to get above the mandibular ligament. I like to do this with the cautery because it bleeds up here if you don't. The blue down by 2 points, thank you. Good. So now we're going to start undermining the subcutaneous flap here, the lipocutaneous flap in the neck. And this is where the tumescence really helps. If it's not tumescent, it's a lot harder to raise this flap. Okay, Army Navy, please. So now this end of the Army Navy is below the mandibular ligament. And I'm going to raise a tunnel in the subcutaneous plane above the mandibular ligament. And now we have the mandibular ligament trapped between these two. And we're going to release it in the subcutaneous plane. And what that does is it helps treat the jowl. And very importantly, it gives me great access into the neck. This allows this part of the wound to slide better. And when we have them both undermined, it makes this one neck incision effectively 1.5 times bigger than it originally was as far as what kind of access you get through the same linear incision. So now I'm going to do the other half of the front of the neck. Same thing here. And this is partially by feel and partially because you can actually see the little lobules of fat draping over the scissor, and so you can tell how deep you are by that. And as I come past the hyoid, I find it easier to turn the tips upward just because it mimics the natural bend of the neck better. It really doesn't matter, whatever's comfortable angles-wise for your arm. And I'm not quite to the purple line at the bottom of the neck yet, but it becomes easier when we have more visibility. So I'm not going to dig too far down in that tunnel, because if I start up bleeding, I want to be able to get it easily. So I'll get close to it, and we'll finish that later. Same thing, that retractor is inferior to the mandibular ligament. This one is going to be up here in the chin pad where we previously undermined. I'm going to create a tunnel subcutaneously, and I have the mandibular ligament trapped between these two. And now we're going to release it right in the subcutaneous plane. And you can travel anywhere in the face in the subcutaneous plane with no worries of motor branches. So if you are truly subcutaneous, you're safe. And I find that's the easiest way to get truly subcutaneous and release that ligament. Again, I used to do it later in the case, but now I do it early so I have good access to the neck. There's commonly a little perforating vessel that runs with that. So I'm just doing a little subcutaneous hemostasis now. 25 of ketamine, please. So I do this all under propofol ketamine anesthesia. At the beginning of the surgery, they are dissociated on ketamine while all the local anesthesia goes in. And every place we've operated so far has been numb on local anesthesia. But we're about to go beneath the platysma. And in the neck, the subplatysmal space, especially the glands themselves, are very sensitive. And they are not numb right now. So we're going to further dissociate her right before we do that. So we have about a 20-minute window to get some of that neck work done. The original dissociating dose was 50 milligrams to totally, completely dissociate her. We're only giving 25 now just to kind of get a little extra for this moment. So if the ligaments are intact, this incision can travel about that far. Okay, let go of the ligaments. If the ligaments are loose, the incision can travel much more. So we get the same, go ahead and pinch it down again. Can you see that? So Megan's the ligaments. That would be the extent of visibility if I didn't release the ligaments up front. Release them. That's the extent of visibility when we release the ligaments. So that's why we do it now instead of at the sides of the face. So I've marked the midline. We're going to open the platysma now. There it is. You can just see we're at the platysma layer. And we're opening the platysma vertically at the midline. And I do that mark because otherwise I get off center. We've opened the platysma at the midline. You can see the back surface of it. And I'm going to undermine behind the platysma and right under the bare muscle. And my assistant Megan and my other assistant Joni are watching for twitching. So they'll tell me. And we see twitches all the time. So the platysma itself will twitch the chin pad especially, and a little bit of the lower lip region. So seeing a twitch is not devastating. It just tells me that I'm getting close to important things. And so maybe if I see some twitching, I'll back off and do some blunt dissection for a while, like spreading like that, or use a scissor. So that's about as far lateral as I need to go. Now we're going to remove some of the subplatysmal fat. So we have the platysma up here. I've gone pretty much to the capsule of the submandibular gland laterally, to the mandible superiorly. And now I'm undermining the fat off of the digastric, or freeing the fat off of the digastric. This is a little bit, it's probably buccal fat, or an extension of buccal fat that comes out from underneath the jaw. There's often a vessel in that, hopefully you don't see it. And then you can just see the anterior pole of the submandibular gland. So that's the anterior pole of the submandibular gland. Midline at the fat down here. And I'm going to go all the way to hyoid. And I'm taking off the front piece of the capsule of the submandibular gland along with this fat. Okay. So you should be able to see super clearly the anterior belly digastric and the anterior pole of the gland. So now we're going to further open this capsule, posterior to the gland and inferior to it. And if she did not have the ketamine right now, she would be all over the place. This would hurt like crazy. So as long as you bovie on the gland side, it's pretty safe. I would encourage you to do a lot more spreading dissection if you're getting started with this kind of stuff. But the more of this I've done, the more comfortable I am using the bovie. But if you want to be super safe, get in the capsule and do it 99% with spreading dissection. So I've kind of scored the capsule there towards the superior surface, and I'm brushing it off the gland with a rough instrument like the Q-tip helps a lot for that. Good. Ligature. So now I have been using this ligature device recently. It costs $400 or $500 per use. It's by Covidien Medtronic. And I'm going to clamp right across it. I have it totally free. And it's an impedance regulated bipolar style device with an integrated cutter. Do it again. little bit left here. And the promise of this device is it's supposed to seal vessels so they can withstand up to 3 times systolic pressure before they burst. So I use this partially because it's faster, and partially because the intraglandular vessel should be sealed well enough to not bleed in a delayed fashion. And there's the cut surface. You can see there's almost no char on that. And so the idea is that the sealed vessels inside the gland should hopefully not have a piece of char fall off 2, 3, 5 days from now and bleed later. So I think this is potentially helpful to minimize the chance of delayed bleed. So there's anterior belly digastric, body mandible, and there's the stump of the gland. And I want to take that at least at the body mandible level. Hers actually I have it even higher. The entire capsule is preserved, the lateral surface anyway. I took the front piece of it off on the way in, and the marginal is going to be up in the lateral and fairly high up in this capsule. So that's our anatomy of the fossa. Hypoglossal and lingual are going to be deep to the floor of this fossa. So there's anterior belly digastric, there's digastric tendon turning right there at the hyoid region. So I'm going to put a little bit of Botox into the stump of the gland. This is optional. I think it helps if they decide not to follow their low sialagogue diet. I think it helps decrease the chance that they have a sialoma later. All right, so this part of the contour that's been created, that was the fat, the hemi-fat pad deep to the platysma. This contour that's been created was the submandibular gland. And so when you see a lot of kind of basic face neck lifts with basic deep neck work, you'll see they expose the front part of the jawline, like from here, but they don't get the shadow that travels back here. And so when we finish with the lateral lift, it's going to finish the last part of that jawline all the way back here. Here's the deep fat, here's the gland fullness. So now I'm undermining the platysma on this side. I want to leave basically all the fat down, but I don't want to injure the platysma itself because I want a strong layer to close. I learned 100% of this stuff from Tim Martin, by the way. Little bits of improvements over time, but the real meat of it all came from Tim, and he learned it all from Bruce Cannell, so I'm thankful for both those guys. Okay, malleable, please. So now we're going to come up under the platysma there, and you can see this last bit of fat that I didn't take. I'm not going to dig between the digastrics, but I'm going to take what's external to them. This is the hemi-fat from this side. And same thing, here's this little fat that's kind of not really subplatysmal fat, it's mostly coming from under the mandible. Often has a little venous bleeder with it, and right behind that is the anterior pole of the gland. All right, so I'm amputating this right at the hyoid level. And I'm going to open the gland capsule a little better, inferiorly, and then free up the gland itself. Like a thyroidectomy or tonsillectomy, we're hugging the actual gland. So now I'm using a bit of blunt dissection. I've got the capsule scored, so now I can just take that scored edge and free that up, just like that, until I get it on the run. I'm not completely free on the posterior side of this device, so we're just going to get the front part going here, because it's kind of in my way. I come right across it. The bigger the gland is, the more likely you have to take it piecemeal. Theoretically, you're supposed to activate this once, and the other few times shouldn't make any difference, but I kind of, just makes me feel better to do it a few times. So you can see the gland is kind of, I've started amputating it, right there, inside the capsule. And this is a little bigger on this side. Let me get a spreader, please. I'm going to free up the posterior surface of this gland a little bit. It's still stuck. You can use a snap for this. This is actually a Viterbo dissector. I kind of like it. I'm getting the fascia off the back of this. You can use a snap for the same thing, same purpose. So now I have the gland even more free. I'm going to continue using this device to amputate it. Obviously key, you don't want to pass point and end up in the facial vessel at the tip of this device, because that would be bad. Okay, so there's the cut surface of the gland. Almost no char on it. You can see where the seal was. This does not stop saliva. It stops bleeding, but not saliva. So we still need to put drains in. Botox. So again, this is optional. I kind of like it because I feel like if they're not perfect irrigation with their diet, it gives me a little bit of safety suction. And I'm injecting the gland under direct vision, so I feel like I know where it's going. Bipolar, please. On, please. And then I rinse out any excess. So I feel pretty safe with it. I've done hundreds of these and I have not had any dysphagia yet. So looking at our contours now, there's a little bit of a digastric bulge on this one side. So I'm going to take a little bit of digastric right here. And I normally do this with a Bovie, but since I've already spent $400 or $500 on this device, I'm going to do this with the device instead. Good. So now that contour looks appropriate to me. Both her glands are injected. She's got nice shadows everywhere. So she's had no lateral lift at all yet, no tension in any way. We haven't even closed her platysma. But she's already got a segmental contour and she's got a shadow 2/3 the way up her mandible. So that's what that deep neck accomplishes. So my landmarks here are the angle of the mandible and the lateral orbital rim. That's where the deep plane entry will be. We're going to start with our lipocutaneous flap though. I used to get real worked up about putting a square corner under there. I don't think it makes much difference. I get much more worked up at the top corner now. I think this corner is critical to get it sharp. I'll show you some tricks there. And then this is right on the edge of the tragus. It's not truly retrotragal. So this is just a basic lipocutaneous flap here. This is, interestingly, I think the hardest part of the flap to raise in the lateral face because it's easy to get into the sternocleidomastoid fascia and not realize it. So even though it's a basic flap, I'd say still take it slow, especially post-auricularly. Here it becomes very easy again. But it's right where the flap crosses the sternocleidomastoid is where you're most likely to get deep and not realize it. So you want to, if you're seeing bare muscle here ever, you're too deep. Just like the neck, a lot of this is now by feel. Feeling the flap thickness as I go. We want to be outside the SCM fascia, so we're not risking the great auricular or external jugular. And I'll do the distal reaches of that when I can see a little bit better. Oh, it might be there. Okay, front. So here we're going to be between the subcutaneous fat and the temporal parietal fascia. I'm just going to carry that thickness forward. And this often likes to bleed, so we usually pack it right after we have it undermined. Although she's being merciful today. And I want to be really meticulous again about this corner. I think it's one of the biggest telltales that we don't pay attention to is the sharpness of that corner. Another hook, please. A little superficial there. And I'm taking it just past that line. Again, I'm telling by watching and also by feeling with my fingers on the backside how thick that flap is. Again, I'm finishing my extent here. Just past that line. And I go just past it so I have a cuff later to sew to. Otherwise, we have to make a cuff of tissue once we do the deep plane dissection. So this gives me a little cuff to start with. So now we're going to take a stapler and just hold this flap out of the way, because otherwise it hangs in our face when we try to do the sideways dissection. If you look at this cartilage always projects further than that free edge of skin, and it makes closing that and creating a convincing corner there very difficult. So this is something I started doing a long time ago. Then I watched Tim Martin do the same thing, and I was really excited. I was like, wow, if he's doing it too, it must be good. So now that cartilage sits behind the skin edge there, and that makes the closure much prettier in that top corner that I'm obsessed with. So now I'm marking again the entry point. The line is from angle of mandible, which is right here, to lateral orbital rim. And I'm also going to mark out, just so we can see it, the inferior limit of the zygoma and the superior limit of the zygoma, just for orientation purposes. The skin is still attached here. That gives tension underneath the smath, and I'm pulling kind of posteriorly and up a little bit. And we're going to expose and develop the potential space right under the platysma. So we're starting to see the platysma. I'm not all the way through it. We're getting more through it. We should start to be able to see our potential space developing. And they're watching for nerve stimulation this whole time. There's a little bruising here, unfortunately. But the plane's still good. There's orbicularis right there. I have adopted Andrew Giacono's lateral face predominantly. It's better than what I used to do. And I'm grateful that he teaches everybody about it. So there's the orbicularis fibers. You can see we're right above them there. So you can still go below them, but there's occasionally a zygomatic branch that crosses between zygomaticus major and orbicularis. And if you get one of those, it's not the end of the world, but you have some weird blinks for a couple months, and it's just not worth it. If the lower lid is really weak, I still might go below orbicularis to help use that as a tension on the lower lid. But this is lower stress in some ways. There's the back of the platysma, smash there. So this is an interesting instrument. This is that Viterbo dissector, Viterbo. When you squeeze it, it opens, and it's got a little tip on it. I like it. Fausto Viterbo from Brazil developed this instrument. It's like an iconoclast or like a Trepsat. It's like a lot of instruments, actually. This one's just like the right shape and size for facial surgery. You can also use a Trepsat. You can also use a facelift scissor. I think this is elegant. And so we're outside the protomasteric fascia here. When I get marginal weaknesses, I'm sure 99% of the time it's from being aggressive spreading right here. And so when I spread there now, I'm much more delicate when I spread. So I used to take that Trepsat and really spread hard, and I see more marginal weaknesses. Trepsat. So now you can see we're under the platysma here, outside the protomasteric fascia, and I'm being this is a Trepsat, so I'm being gentle with that. Here we're over the orbicularis. I'm going to stay over the orbicularis. I'm going to spread into the anterior midface. And I have my finger in there, and I'm into the anterior midface, and she's also stuck right here. That's so interesting. Most people, this will slide right down. She's tight. So her zygomatic ligament patch is very strong. Normally I can break through a lot of this with my finger, but it's really tight and strong. So I'm in the anterior midface here. Okay, let's pack that. That also likes to bleed. We're going to temporarily pack the front part of that while I continue with access. Army, Navy. Another Army, Navy. Okay, so now we have our two pockets. Megan's doing what I call bunny ears. She's lifting and going outward, and that helps stretch that out and make it straight. We're going to continue that plane. Over here, I want to be external to zygomaticus major. External to protomasteric fascia, outside the buccal fat. And once you get past kind of a certain key point here, if you spread hard enough, you can just spread over zygomaticus major. Let's get that Viterbo. And so I'm going to start doing a spreading dissection to tear zygomaticus major down off the flap. This is all this fibrous stuff. None of this is important. So I'm feeling zygomaticus major is on the floor of my dissection. I'm going to follow that inferiorly. You can actually see some of the muscle right there. So I'm subcutaneous, basically. In this space, Subsmass and subcutaneous are basically the same place. I'm following this all the way down to the modiolus. Again, I'm just going to continue the same plane. Anything stimulating? Good. Returbo again. And you can, again, use a scissor for this. You can use a trap sat for this. I just like this little dissector. Again, we're basically in the subcutaneous space here. There's not a lot going on there. And so you should be able to see the extent of undermining is up over the malar cheek, down here. And I'm being gentle here because I think most of the marginals I get are for being too aggressive right here. And they're temporary, but I still don't like them. So that's a pretty good mid-face dissection. Let me have the turbo again. And again, I'm being intentionally a little bit delicate right in here. So we're taking the platysma still off the deep fascia. And I'm freeing it from the anterior surface of the SCM. Good. I want to make sure I'm behind the angle of the mandible. Good, relax. Behind the angle, all this stuff is unimportant. I'm still going to be gentle. And if there's little things that look nervoid, I'm going to try to leave them. So like this could be a little branch right here. So we're going to leave that. Doesn't need to come anyway. This is probably nothing. Come on. I'm going to delaminate the flap, take the SMAS platysma unit and the skin apart just right along the jawline. That'll give me some independent vector and also make it easier to get back into the neck later in the case. At the very end of the case to do the subcutaneous sculpture. So I'm just letting the SMAS platysma off of the surface of this flap now. Good. So I'm right about there. That's free communicated down into the neck. I'm over zygomaticus major. You can get a sense of some of the buccal branches right under this flap right here, under the fascia right there. That's a buccal fat pad. If we wanted to go after it, we could. So now, before I inset this, I'm actually going to put the drain in, put it subplatysmal, and close the platysma. It's a fully fluted drain. So I'm under the platysma. I'm going to pierce right through it, and then grab the tip of the drain. And this will be how we get the drain into the subplatysmal space. And I just have to be careful not to sew it in. Tim Martin uses a right angle retractor and puts the drain in later, so you could do that too. So now we're going to put her platysma back together, and we'll grab little bites of the floor of the mouth, or the hyoid in this case as we do it, just to help anchor. And this is a 2-ovicral. Soaked in antibiotic solution. Just our normal antibiotic irrigation. And if I'm doing an isolated deep neck lift, actually I just do this neck portion and redrape the skin from the neck incision, and that's it. If I'm doing a neck lift with a facelift, I still do everything down here as thoroughly as I would if I was doing an isolated neck lift, but then we lift the lateral face at the same time. A little deep bite of the platysma. And the opposite platysma, and I'm making sure I'm not capturing the drain with any of those. I don't like grabbing the thyroid and strap muscles and everything of these bites. I'm afraid it'll cause strange animation when they swallow, so I don't do that. These are just inverting simple sutures. And I like to close this beyond the hyoid because I feel like if the platysma closure fails above the hyoid, they see it really prominently as a gunshot kind of defect. And so if I stop closing at the hyoid, then there's nothing to protect that. All the tension is right at that first stitch in front of the hyoid. And so I feel like closing it below this helps protect the important part of the platysma closure even a little bit more. I still get failures here and there, but I think this makes it less. want a long face-off scissor after this. Before I cut the stitch, I'll use it. I'm just trimming little bits of excess fat here. I'm kind of feeling that I don't tie a suture at the same time, just as I close the scissor. Okay, let's put a hook in, go forward. So now we're going to close a little bit more anteriorly where I stopped earlier. Out, please. Let me feel. Pardon me. So I'm just checking that I like the closure, just kind of feeling initially. There's a little bit of fullness here I'm going to take right now. Come right here, Megan. Short end Army Navy. I know this needs to go, and it'll be a lot harder to get here once I have the sides of the face inset. So since this is kind of loose right now, I'm going to take this opportunity to get rid of this little ridge of tissue. We'll do the final fine-tuning at the end of the surgery. I like the overall contour. I think that looks really nice. There's a little bit of a fullness right here, but that always falls in, so I'm going to leave that. So we're going to inset the first side of the face now. So we have not yet inset the smash flap, but we've closed the platysma. So you can get a sense that this shape is all done, again, before we've done any lateral lifting at all. So I think that's one of the reasons this does really well and is really durable, is because it's not dependent on the lateral tension. So you have a really good view through the fascial floor of the lower buccal trunk. It's right there. You can kind of see it. If we slide the fascia over, you can really see it. And the marginal is right there, right through the fascial floor. So this is a bidirectional barb suture I've started using. It's called Stratafix. You could also use quill, or you could do what I used to do, which is use Vicryl. But I think this is kind of nice because it's fast and it creates progressive tension. Although again, with all that release, you don't need a whole lot of tension per se. Relax, actually come out all together. So I'm making sure I'm not creating too much bunching up here. We're almost full on the lift. Come back in. Out again. That's about as much lift as I want. Now the rest is just going to be anchoring. Come back in. It's easy to overlift at this stage. So the rest of these are almost just transverse. And this is this little cuff of tissue that by undermining a little past my line, it creates this cuff automatically. Out, please. That's acceptable. Okay, come back in. Out, please. So that's my smash inset up top. We'll work this little bit of bunching out when we do our brow lift. Come back in. And a little bit of bunching there is acceptable. It can't be excessive, otherwise it'll never settle, but a little bit will settle. That's one of the challenges. Once you get really good at mobilizing the smash and lifting the face, it becomes a skin management issue and judgment issue, and I still face that weekly. That bite was a little close to the ear, and it would have pulled the ear forward if I'd kept it. And on these bidirectional sutures, before you cut them, you have to take at least 1 or 2 steps backwards to terminate the run. So now I'm going to release the platysma just inferior to the angle of the mandible. We know the marginal branch is safe. We've seen it. That'll be our platysmal transposition flap. And here comes the other end of this bidirectional suture. This little piece is stacking up on the mandible angle, which is nice. I'm actually going to fold a little bit to generate even a little more of a bump there. Good. Now we're going to skip a little lower here, and this will be my inset inferior to the angle. I'm feeling the angle of the mandible because I want a little gap there. So I'm going to skip a little lower with this next bite and then capture that. I don't want it up high, I want it down low. May I have a facelift scissor, please? This little tissue likes to bunch up here, so we're going to thin that out a little bit. The subcutaneous fat over this pennant likes to bunch up. And we don't need to pull this hard laterally. We have the closure up front already. We have the foundation set already. So there's not a lot of reason to pull this really hard laterally and generate posterior skin excess. It doesn't really do anything good. So this is more just making it snug, because as I showed you a few times, the contour on the front's already done. I'll take a back step here. And one more. And we'll terminate with this one. Out, please. Staples out. So now we're going to check that I like the overall lie of this. So I feel like she's actually too tight here. So I'm actually going to undo that and make it less tight. So first time for everything, take that. So the thing is, it's so mobilized, it's easy to overlift. And so I had this part well, but I felt like this was too lateral and too tight. It was flattening her across her orbital rim, and her canthus was distorted. So I didn't like that at all. So I just took it all back out. We're all free again. And we can do it again and be less complete on the lift. So that's one of the things when you have a really good mobilization, so you can overdo it. So we're now totally free again. Let's irrigate into theirs for kicks since we can. But good teaching case, right? You can do it again. Better now than 6 months from now. Okay, let's see what everything looks like. We'll check again. Come out. Good. Back in. So again, I'm just going to nail it down. I'm not going to ask for any more tightening or lifting because it's easy to get too much on her. This is more now just securing. Relax a little bit on your retraction, I mean. We never want it to be tight. We want to take the slack out of the system, and that's it. This is basically, it's PDO, so it's a PDS-like material. So here I am over the angle of the mandible again. Good. We're going to step this inferiorly. And that little tail. Not putting a lot of tensioning on it, going inferior to the mandible. Okay. Suture scissor, please. Needles up, out. Let's see if we like that better. It looks better from here, much better. So now I'm looking at the skin drape. That looks really good. We'll take care of this with the brow lift. That looks really good. Splash onto the next side. Okay. Angle of mandible. That's our smash entry point, but we're going to undermine a little beyond that to create this cuff of tissue to work with. Blade. So there's a tragal incision, double hook, long scissor. And same thing here, subcutaneous, stay out of the fascia. Easier to get into than you realize. And again, kind of by look and kind of by feel. We're going to finish this undermining. Go at least to our line, beyond it just a little bit. If we don't get it all now, we'll get it later when we can see. Okay. Double hook. So between the fat and the temporoparietal fascia here, right there. And this usually bleeds, so we're going to pack it in just a second. Packer, please. Good. Let's do a double hook right there. Good. Good. Room lights out, please. Now there's the temporoparietal fascia down there. Okay, so I'm just confirming I have the degree of undermining I want. So I staple this. I don't have it pulled all the way forward because then it often staples into the part of the flap that I'm trying to get to. So I have it partially folded and stapled. So there's the part of the tragus that's going to be in the way to generate that corner later. Take that. Okay, good. So we're going to make the same entry. Angle of mandible. Zygoma. Lift up real good. DeBakey Bovie. And watch for jumps. So here's the potential space between the platysma and the fascia.
relax for a second. Some well over zygoma, that's good. Orbicularis. Seeing a hint of it right there. And they're watching for nerve stimulation as we go. There's orbicularis down right there. I've already gone through some of the zygomatic ligament at the origin. All right, let's switch to some blunt dissection. So again, here's where I become more delicate because I feel like this is where I get my neuropraxias if I'm going to get them. It's the easiest part, so you want to power through it. But I think it's where you end up paying for it later. Over orbicularis here. I'm going to switch to that Trepsat now. Bring that all the way to the, pretty much the side of the nose. Finger. So I follow that same tunnel, and now I've swept there, so I'm above the patch of zygomatic ligaments now. All right, so now we're starting to come through the rest of the zygomatic ligament patch. Once you get to a certain point, it's easier to just spread it. Okay, super spreader. So you can see zygomaticus major underneath me there, and I'm just pushing it down off the flap. You can often do this with your finger. Let me take this to the modiolus. That's it. That's our complete midface dissection. Again, I'm being a little cautious here because, again, this is where I think I end up getting some of my misery. And now let's take it off the SCM. I'm just following the anterior border of SCM now. I'm just going to feel I'm truly behind the angle. And I'll make a little release here. All this white fiber stuff back here is nothing. Relax. Good. So I'm well mobilized. I'm going to release the SMAS from the skin. Just right along the jawline, which allows me to get back into the neck later. It gives me bidirectional advancement of the skin and SMAS. I could release it more if I want to, but we're going to fully laser resurface her. So I'm going to keep that as minimal as I can. I'm just releasing a little more here posterior laterally because I know it'll need it to swivel the flap into place. All right, so let's inset this SMAS flap. It's turning into a beautiful neck. So this time I'm not going to go crazy on my first pass. A little antibiotic irrigation just for kicks. Take that. Come out, let's see what the temple looks like. Okay, come back in. So I'm looking for temple bunching and lower lid distortion are my two landmarks for, okay, she's had enough. And usually the temple bunching happens first. On the other side was the lower lid distortion. Out. Okay, come back in. Yeah, she's just starting to bunch a little bit, just starting to crowd. That's it. So now I'm just closing this, anchoring it down, not asking for any more lift. As a matter of fact, sometimes if it feels like it's still wanting to lift even more, on the way back we'll kind of put the stitches in at the opposite angle to make sure it doesn't overlift like that. Is it okay? Let's see. Yeah, I like that. Okay, come back in. Needles up. Okay. So we're going to go ahead and release the platysma inferiorly here to the mandible. Make our little transposition flap. So that's that. That'll set down low.
Over the angle. So I'm going to step down lower here so the transition flap sits low where we want it. And go ahead and inset it. I'm just going to trim some of this excess bulk it likes to show later. Good. Good. Mm-hmm. Okay. Now we're going to assess everything. She's not bunched in the temple. That drape's good. I don't think I need to mobilize any more skin there. Maybe just a little bit. Her eyes are not too tight. Her cheeks look good. Her jawline is exactly as we want. We have the shadow finished all the way around the back now. I think that looks good. Okay, so let's close the first side. And essentially no tension here. And then again, this is why we don't want to have to come up to cover something like this, because that puts the flap in a weird direction. It's really just straight posterior. Because that's a normal Burroughs triangle. Okay, staple please. So we're just going to temporarily inset these. And close them finally in a little bit. This will all be replaced with fine suturing. 6L. Alright, so we're going to release the lobule now. So we're going to inset our lobule now. Again, a little crowded is good. So Megan's pushing the tragus, the little dimple in, to make sure to leave plenty of skin to drape into the pretragal dimple. You can let go, thank you. And again, that's a Tim Martin thing. He probably learned it from someone before that. Stitch, please, 6-0. Okay.
4, 5, 6, 7, 8, 9, 10, 1, 2, 3, 4, 5, 6.
Supercut curve. Mm-hmm.
7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Flat. 1, 2, 3, 4, 5. Suture.
Come out. Just doing a little bit of fine tuning of the shape of the tragal inset here. Bottom one. Q-tip, please. Supercut curve. Okay, let's do the other side. Stitch. So now it's really difficult to get back in this chin, which is, if we didn't have this undermined, it'd be impossible to get back under the chin. So we try to do as much as we can. That's why we're not closing the platysma now. That's why we closed it early in the case when we could still reach under there. All right, so there's our low drain. And this drain, the deep drain, 4 to 5 days. So we want to make sure their saliva doesn't start producing. The superficial drain, if they're good in a few days, you can take it out. But the deep drain I really need for safety. That's a neck. I'm happy with that. All right. Let's get brown, irrigate, please. And the dry sponge brown marker. There's like a little lump right here. I want to see if I can treat that. Short end Army Navy. DeBakey Bovie. I'm just going to take some of the fat right at the hyoid angle. Just to see if I can accentuate that hyoid angle just a little bit better. Out. That's better. And maybe a little bit more. So let's release that a little bit and see if that helps. Nothing jumping. Shouldn't be dead midline. Out. That's better. I think it's a cleaner angle. So I took a little bit of fat. I even made a tiny baby myotomy right at the hyoid. Nothing significant, like a 1/2 centimeter myotomy right at the hyoid. And I think that improved the angle a little bit. All right, 10.
And do you want to inject the lip before you do the brow?
Yeah, that's a great idea. And I'll sneak out while you're doing the final closure, but I'll do the gliding brow anchors. So that's part of the lift, kind of. Like that. Six up. So this is the 5.0 chromic, and we leave this in for till it falls out pretty much. Six oh. So I'm kind of tracing where the flap needs to be. Take that. Cut. Bottom. Cut. So we're going to preemptively inject her upper lip because we'll be back here shortly to do the lip lift. And we'll re-inject it when we get started because the lip lifts just bleed. And I'm going to be actually maybe a little more conservative. I'm going to cut inside my line today. And we're also going to inject the entire area that we're going to undermine with the lip lift. It doesn't close right if you don't undermine far. So this is the brow that needs a little more attention. This needs less. They both really only need it on the temporal aspect. And I like this little gliding brow lift for that. If they have heavier tissues and they need more of a glabellar lift as well, I'd say 75% of the time I still do the non-endoscopic endo style brow lift. And maybe 20-25% of the time I've been doing this lift. So what we're going to do basically is just subcutaneously undermine this pocket, shift it up, and tack it back down. That's it. We're going to do it through a 1 centimeter incision. Double hook. So that's the straight dissector. It's a Viterbo dissector. You can also do this with a scissor. You had to make a bigger incision to use a scissor. So I'm feeling that I'm in the subcutaneous plane. I don't want to be in the muscle or under the muscle. So I'm subcutaneous. You can see the contour of my dissector. Just making tunnels. And I'm feeling my thickness here. But it's important that I'm truly in the subcutaneous space. You can see that by the thickness of the flap. If you've ever raised this skin, you know how thick it's supposed to look. Now coming behind the hairline. Now we're going to take this right angle and we're going to connect all these tunnels. And this is the trick. You have no way to control hemostasis here, aside from the Auerswald net. And so that's why, if you're doing it with these instruments, you need to use that net. If you're doing it with a scissor, it might be a little harder. The net's your hemostasis maneuver. So that's good. So this brow didn't need a ton, but that brow is now mobilized. And we're going to tack it into place. Let me have the stitches just the way they are. Actually, I don't need the double hook just yet. And these couple tackers are going to stay in for about 5 days. So this is a good procedure for shaping the brow. You can bring it all the way down the lateral canthus, and you can do kind of an external leaf lift of the canthus. And you have to overcorrect a little bit because it will slide down on you a little bit. And so that's kind of part of the judgment. Now we're just going to close all the dead space that we just created. And these two will stay in for about 5 days. Look, this net will come out in 48 hours. This is just to obliterate dead space. And now we're just re-securing the skin and fat back down to the muscle.
keeping her from getting a hematoma here. This is the hemostasis in this procedure. Take all the slack. Go ahead. Again. So this is the Arswald hemostatic net. So it's a lipocutaneous flap, repositioning the brow, and a hemostatic net. And tie this one. Okay. So in many cases, if you do this, they'll be actively bleeding out of that, not horribly, but bleeding. And you just ignore it, and you close off all the space from distal to proximal in that incision, and it controls it. So it's both anchoring and hemostasis. I'll do one more little baby run between those two. And we're going to laser over the top of this, and it usually survives. Once in a while, we'll get a break, and we have to tie it to some, and re-anchor it. But it usually survives the laser. The proline usually survives the laser. When I do my normal brow lift, they're headachy for a couple days, and some of them get nauseated. These guys don't even notice. They look funny, but they feel fine. So the comfort is dramatically better. Let's do the other side. The other side needs a little higher lift, and this is the Viterbo gliding brow lift. I'm doing this by feel. I'm not trying to obstruct your view, but I need to feel what I'm doing. This has a little higher incidence of temporary brow weakness, in my opinion, than the other brow lift does. I think it's because we're roughing up the surface of the frontalis a little bit while I'm doing this. So that's one thing to know about. But as long as you're in the subcutaneous plane, the nerve itself is safe. And you just, it's so easy to tell and feel that you're in the subcutaneous plane. It's really not difficult. Right angle. Just letting down all the little pillars bluntly. Staying right under the dermis. You could also do this like a liposuction cannula, like a little spatulated liposuction cannula. You wouldn't put it on suction, obviously. But can I see a 2.4? So this would be perfect. You could do this exact same thing by taking this flat lipo without suction, no suction, and doing the same undermining I just did, and then taking a little scissor and breaking the tunnels, or even just taking this and breaking the tunnels. So if you don't have the actual Viterbo, it's still doable. I need to release a little further back here to get the lift I want. She's bunching up a little bit at the hairline, so I'm going to take it a little further posterior. Good. Good. Okay, let's get the stitch, please. This is our anchoring suture. So we leave those a little bit long as a signal to the post-operative team which ones they need to leave in. They should be able to tell just by looking, but it's just a nonverbal cue. Okay, come back in with that hook again. Okay. Out, let's anchor, huh? I've left them in 48 hours and 72 hours. They don't leave a mark in either way. I have not left them in longer than 72 hours. I'm going up a little higher on this side because I actually undermined a little higher on this side. Okay. Another one? It's checking that she's closing. She's closing on both sides enough. It's good. And this will relax a little bit because she's at a previous upper bluff. Okay, marker, please. This is just for my laser purposes later. Good, good. Good. I'm actually going to cut just inside my line here. I'm being even a little more conservative than I had drawn, especially in the middle segment. This is her low lip, so I'm being I drew it a little more aggressively here. Okay, good. Suction bovie. Dry sponge. So I'm just deep sub-Q here. Not a lot of... But it drapes more normally if I have some undermining. Okay, stitch. You have damp and dry Q-tips, correct? Good.
replacing that one. Like that. High five. I'm going to take the first stitch back out. 0.5, needle driver, or suture scissor, load that double. Not a lot to this. Cut it out, close it pretty. Is this our only 5-0? Go ahead. Yeah, please do.
Can I get a 50 PGA gel? This is 6-0 now. It's doing finer tuning. Dab for me. So I lock some of these. I don't lock them all. I lock some. It makes it easier to get out when I don't lock them. But sometimes I'll lock them just to hold tension. So I just lock the ones I feel like need to be locked. So now I'm marking the bottom of where I'm going to stop lasering. I'm marking where the skin flap was. It's already marked actually, so I can be conservative there. Wet and dry. So just for sutures, the net was 4.0 Prolene. You could use 4.0 or 5.0, that's fine. These were 6.0 proline. There's some simple interrupted 7.0 Vicryls around the tragus to keep it from shortening. 6.0 proline, chromic post-auricular, and then proline again at the hairline. And then we have proline at the chin. All 6.0 proline. All right, so the last thing we're going to do is do her laser resurfacing. I have her marked at the bottom, just under the shadow line that we're going to stop. We'll do a lighter pass here, probably like 50 millijoules in 4 density. And we'll do kind of a 60 and 5 through all this area, and maybe a little extra pass periorally. And we'll see if this pops or not. They usually survive, not always. So if I were not lasering the whole face, I would still do this much of the lower lid in most people just to contract the skin. Take the size up, repeat right down. And that's for efficiency's sake when you're doing the rest of it. So we're still at 60 and 5 here. Wish me luck. It's gonna be okay. Second pass on the lip there. Go ahead and flip that airway out. So I'm going to take the density down and the intensity down. So we're down to 50 and 4. 50 millijoules, 4 density. And we're going to feather the jawline here with that and the flaps. And this has been uniformly safe. This 50 millijoules 4 density over the skin flaps has been no problem. I think we're good. All right, turn it off, please. Jill, she seems to be doing okay with that airway. Can I leave it out? Yeah. Okay. And the last thing we do is we remove her eye protection. I got him. Is I'm going to make sure the lower lid is stretched so that it's not overlapped the wrong way on the back side. Where that incision is. Let's not step the wrong direction. That's good. No lag ophthalmos. That's exactly what we want. Looks just dead on. All right.
So I hope you enjoyed it. That was a good example of a pan-facial restoration. A lot of it went as expected. The gliding brow lift is pretty straightforward. It's a really good choice in her because she didn't need heavy glabella fixed. We got the skin redistributed. She'll have an easy recovery, and we could shape each brow independently. Nice, easy procedure, a good one to get introduced to, the turbo gliding brow lift. Lower lid's a little bit of surprise. We knew she didn't have a whole lot of fat, but it was a little bit surprising how difficult it was to find the nasal pocket. I do lower lids all the time, so even for anybody, it can be difficult to find the nasal pocket or the temporal pocket or something once in a while. The sides of the face went exactly as expected. The one surprise there was just how easy it was to over-tighten the first half of her face. So I think it's really good to keep in mind with these release-based lifts, when you really release things well, you can get a lot more motion than on a tension-based lift. And so if you put too much tension on a release-based lift, you can get a little over-tightening. So it's really good to actually assess as you go. All right, that needs to be undone and redone. Get an opportunity to do that. The deep neck went just as expected. She had really pretty anatomy. Her capsules were really pretty. They were not stuck to the gland, so hopefully that was easy to see and easy to understand. And then the laser was just the laser. The lip lift is pretty straightforward too. So I hope you enjoyed it, and thanks for watching.